So welcome everybody to the EHC World Hemophilia Week session in terms of talking about some of the science that's out there, what might be coming in the future, what are the current impact of the current replacement therapies. And what we're going to try and do in the next hour is kind of bring up some of the topics that are being discussed on all of these products in the current situation and for the future. So with me today, I am being joined by Professor Flora Pavandi from the Hemophilia Treatment Center in Milan, Italy. And I'm also being joined by Dr. Robert Klamrath from the Friedrichshain Center in Berlin, Germany. They are both the chair and vice chair of EHAD and exceptionally knowledgeable in the area. So thank you both for joining me today. Flora, let me start off with you. Can I ask you the first question? And that is, I remember a couple of years ago, you were presenting at the EHAD conference. I'm pretty sure it was Madrid, where you presented on the introduction of the extended half-life products in hemophilia treatment centers. So that was probably 2018. I was wondering if you could tell us what sort of impact have they made in the clinic? How many people are switching to higher troughs? How many people are switching to less frequent infusions? Are the benefits in terms of quality of life really coming through as part of patients' lives?
Thanks very much. It's nice to be with you today. Yeah, you're right. That was the first time I tried to bring the very, very preliminary data. And that was a survey done by, actually one of the first survey done by EHAD, trying to understand what was the benefit of the longer-acting products. Following to that, I tried to follow the real-life data and to understand what we learned from the clinical trial, and the preliminary results is going to be confirmed. And fortunately, I have to say, at least what I get in my center, which is a large center with a significant number of patients, it seems definitely there is a benefit to use the longer-acting products. Because with factor VIII, at least at the beginning, I was not very much confident how could be the reduction of the amount of the product that we are using. So now I'm pretty sure with the data that we are producing, and I hope the other scientists can bring the same data, that is about 30% less. And the number of infusion, at least you have one infusion less a week. However, I have to say I learned also the importance of the PK, because with some of the longer acting product, you might be able even to have a very good results with a good trough level of 3% to 5% using it every 5 days. And in a very small portion of the patient, I would say in 10%, at least in my hand, that we can see they are very good with using once every week, which we haven't seen it with the clinical trial data. And of course, that is something that we need to understand better and better in the future. So that is the situation for factor VIII. As regards factor IX, the situation is even better because, and even more complicated, I would say. Better in terms of the reduction of the amount of the protein, because we can see that you have a reduction of 50% and about the total amount that you're using, and also about the number of infusion that is significantly reduced to once a week or every 10 days, and in some very few cases, every 2 weeks if there are no very active life. But we might see some differences in terms of distribution of factor IX. And that, I think, should be the matter of the research in the future, and understanding the differences between the products and how that would have an effect in terms of protection, and how much the level of plasma factor IX could reflect the clinical situation of the patient. I think that's what we want to see. But overall, I would say this was a big progress, and we are seeing a very good results on that.
Thank you, Flora. So that some of those points are really, really interesting. I think we're seeing in Ireland, we reported about 8% as a trough in factor 9, and probably about 4 or 5% in the factor 8. So yeah, I think we're seeing something quite similar. Robert, you have recently worked on, I saw a publication on the PROPEL study, and you were looking at 8 to 12% trough levels in the hemophilia A space using long acting. I think that, I think that's going to show us all the significant benefits of joint deterioration in the future. But I want to kind of come back to the short-term aspect for a second. I think one of the questions that we are constantly debating is what is more important, the peaks or the troughs? And I think the study that you've worked on, it was really interesting. You get a trough and then of 8 to 12%, and then you effectively get the peaks as a bonus. So I'm wondering what patients do you think will choose that type of approach over something like a bispecific antibody or some of the non-replacements that are coming out? And is there anything in the future that might give us best of both worlds?
Yeah, thank you. Hi, Declan. So I think we get over the times more and more ambitious to prevent bleeding, and patients get more and more active. And I think that peaks are important if you are very active doing sports, playing soccer, and you know that our kids at school and the young adults, they do everything. They don't restrain from any sports activity. And for this, I think peaks are important. And the PROPEL study showed that you can, with a higher intense prophylactic regimen, you can avoid more bleeds in these patients. And what I think what was very important from FLORA is the second point of the study is that individualization is key, because patients are so different. And there were some patients who used less factor in the high trough level group than in the low trough level group, because they had a much longer half-life. So adapting treatment with a half-life of factor 8 is from my point of view, an important task to enable patients to more protection. Second point is that with standard half-life factor 8 product, you have more or less to inject daily to have these levels. And with extended half-life products now, we are able, and for most patients, it was 3 times weekly, up to 4 times weekly, every other day, to keep a trough level of 10% and have a higher protection. So I think in the future, of course, if I explain it simple, I think the trough level is important to avoid any spontaneous bleed. And the peak level is important to avoid traumatic bleeds during exercise, surgery, whatever.
That's great. I think one of the things that we are seeing in the future is other products that have a even longer half-life. So I think it's the BIV001 has been showing some really interesting results as well going forward. So I think we're moving to a much more ambitious space around improving troughs and protection in the future, which is something that I think all patients want as we move forward. Flora, moving into the non-replacement space a little bit. We've talked about our ambition, so let's talk about our ambition a bit more. We've seen the bispecific antibodies have been really, really beneficial for those with inhibitors. We're seeing more patients with hemophilia A without inhibitors get access. We've also seen some bispecific antibodies come into clinical studies, such as Mim8, discussions on the next 007, the James Bond version. But my question to you around the bispecific antibodies in the future is what would you want to see around the next generation or the next edition of the bispecific antibodies?
Good question, but it's difficult to answer, because I think this is a main question for all of us, for physicians, for patients, for healthcare, and also for the people who have to calculate how much we have to spend for hemophilia in the future. So I think what we want to make sure is 2 points, as always. First, safety, and then is efficacy. In terms of both safety and efficacy, the data obtained until now for the first non-replacement therapy which has been authorized and Libra are very positive for both patients with inhibitor and without inhibitors. There are a few aspects that we need to understand. There are the different rates in terms of free bleed patients, and we need to understand better whether the patient can understand the minor bleeds, if these minor bleeds are existing or not existing at all, and how we're going to evaluate that. We can evaluate that with more attention to our patient for the long term. And one of the main points that I want to consider, at least in my center, what we do, using the ultrasounds, for example, for the care of the joint is extremely important. And for example, there are some patients that are coming to our observation, they don't know if that's a bleed or is not a bleed. And we have to understand that. Until now, I would say the results are extremely good. And I'm always listening to my patients. They are happy, the quality of life of patients have been changed. And I think there is no doubt about that. The treatment of breakthrough bleeding in patients with inhibitor is a little bit more complicated, and based on where they are localized and how many hemophilia centers are there, could be a little bit challenging, but people are learning more and more. So I would say joint health should be the main focus. I'm pretty sure we solved the problem of the spontaneous major bleeding, but about the minor bleeding and trauma-related bleeding and what should be the size of the trauma creating the bleed, I think that's something we need to understand a little bit more, and also minor surgery. But all over, I would say the results are extremely important. And other products are very much welcome, and I hope more and more products in terms of non-replacement therapy could come, and some of them they are in clinical trial in a very more much advanced position compared to before. For example, we have fitusiran, some of the anti-TFPI, but that ones we still have to understand better and better their safety in order to understand how to use them. The main point is what is the power, hemostatic power of each single non-replacement therapy, because that is, to my opinion, still is not clear, because we are not measuring factor VIII. And the similar factor VIII, I think that's something really not correct, and we have to be careful about how we are using that. But of course, we need to understand, having parameter of understanding what is the power. And when we learn that better, we know how to use each single product in which frame of time and the situation of each single patient. So that would be my position in the actual position, because it could change and it's so dynamic.
This is why I love this space at the moment, because everything is so dynamic and things are changing so rapidly. I think the hemostasis point is a really interesting idea, and I think one of the things that we might see in the future is not using a factor level as a guider for the amount of treatment or factor that you should get. Maybe it is a thrombosis level that we're looking at. Robert, Flora mentioned the rebalancing agents. There was a couple of updates at EHAD this year, and I'm wondering what should we expect from that going forward in that space?
I think the rebalancing agents are very interesting options, because you can use it in every type of hemophilia without and with inhibitors. So that's a great advantage. The risk is normally we replace the missing factor in hemophilia A and B, and this factor was in the system of the coagulation cascade well regulated. With rebalancing agents, we change the coagulation cascade. So if we knock out an inhibitor like antithrombin or TFPI or protein C, you have a difference in the coagulation cascade. And for sure, one point is sure, that if you use, in addition to knocking out the inhibitor, factor concentrates, then you have a high risk of thrombosis, because the coagulation system is shifting in the direction of thrombosis. What is, from my point of view, that is quite clear, and we could handle this. With fitusiran now, what was a little bit more scary from my point of view, that 3 patients had thrombotic event without additional factor concentrate, because the antithrombin in these cases was very low, below 10%. That was reported on the EHAD Congress. by the company. And of course, now you have to think about, if we go towards normalization in coagulation in patients with hemophilia, we will always have a thrombotic risk. And then we have to calculate how high is this thrombotic risk. And the first measure for Peter Dorian was to say, okay, we have to go for a new antithrombin efficiency level to avoid these thrombotic complications. And I think we need, of course, more data to see how successful this is, because from my point of view, in the non-factor replacement treatment, efficacy seems to be quite well, but safety still needs to be proven.
I think that balance that with the rebalancing agents is so vital. In terms of a term for a product cohort or a product class, that balancing is more than just what you're trying to do with the coagulation center. I think the actions that they discussed around the that new criteria of kind of 15 to 35%. So now we have a very strict lower end. We have an upper end, and it'll be interesting to see what comes out of that space, as well as the other products as well around concizumab, mirtuzumab, the SerpinPC. But they're all very, very different in terms of the way that they work, and we look forward to seeing pretty much all of them in the future. The other point I do think that is really interesting is the point that you mentioned on thrombosis, because I was reading something recently with thrombotic events, and it was a factor concentrate, and EUHANET have now started to report the impact on or report the number of thromboses, and that kind of moving towards a more normal population in terms of clotting. That whole area needs a lot more attention from all of us for all of the products. I think we're moving on in time, so I'm going to move on to the gene therapy space quite quickly. Robert, I'm going to come back to you around this question. So what are we seeing in relation to response and durability for the gene therapies, and is there a difference starting to develop between the factor 8s and factor 9s in relation to gene therapy?
Well, again, that's a very difficult question and challenging. So I think first there is a difference in gene therapy for factor 9 and factor 8 in hemophilia A and B, because all the data we have now in hemophilia B is that there is a constant expression of factor 9 over a period of time of at least 10 years, which I think is pretty sure from all over the different trials. In hemophilia A, we saw a decline in factor expression over the years. It will be very interesting to see if it's a plateau or if the decline will continue. What I think what in both gene therapy is a major question for a patient is the huge variability of outcome. How high will my factor level go after gene therapy? And if you look in the factor 8 space, there's a huge differentiation from nearly nothing to values up to 200. And in hemophilia B, it's more or less the same. You'll be aware of the Unicure trial, the phase 3 trial, the 6 months data is out. And there's again a huge variation in outcome for the patient. And at the moment, at least I'm not aware, and I hope the data will give this information in the future, in which patients we can expect a good outcome, like a normalization of coagulation, and in which patients we cannot. And that at the moment, from a patient perspective, very difficult, because I cannot promise how high your factor level will be after gene therapy and how well you will be protected.
Yeah, I think one of the things around the variation that's going to be really important for us all is the hub and spoke model, and the reason for that is for us to provide or create a number of patients who are interested in getting treatment, but also for us to learn off a small cohort how we minimize that variability in terms of our discussions. What is the difference between one patient and the next? I think there was a presentation recently, and the most we can definitely offer is 5% for 5 years at least. Now, you may get way, way more than that. You may get way, way longer than that. You may get a better response. Everybody may respond, nobody may respond. But it's really interesting that, that is the limit. And that actually has a significant benefit around patients. I think somebody in that group highlighted that, even if you were to give me that when I was in my 20s and I could go and travel the world without worrying about my condition, that alone would have been huge. And I think we are seeing much greater possibilities with some of the products in the future, and what to expect. But we do have a lot to work to get there. Flora, so we've talked about factor levels a bit. Can we just go and talk about kind of the long-term safety aspects and also the short-term safety aspects? Are we getting to the point where we need to understand more about the steroids or the other immunosuppressant aspects of care? What will be the regime? How long will it last? What should patients be asking themselves when they're thinking about that part of the gene therapy decision?
We need to make clear question to us and trying by time to answer as fast as possible and as accurate as possible to this question. In terms of short-term or intermediate-term toxicity, as you mentioned, we have the issue of liver enzymes, and the increase of liver enzymes in a portion of patients, which is about 30 to 50%, based on the type of the vector that has been used, the amount of the vector, but still we do not find a clear cut situation about what is exactly the relationship between the amount of the vector or the type of the vector. And if you look on the data, every clinical trial have their own data, and the heterogeneous result is making very difficult to come up with a clear conclusion. For example, what type of steroid to use, when to use, upfront to use, or when only the side effect is coming out. I think for this point of view, we need to understand a little bit more and following very well our patients. But in the meantime, I think there are few companies, they having the results of about 3 to 4 years, or those number of patients that have been treated with clinical trial. For example, BioMarin for next year would have a large number of treated patients, and they have a data on the steroid therapy. And we can analyze they should bring that data as soon as possible when the data is completed and clean. That will be the first set of data in terms of steroid treatment. Whether there was any relation between the usage of steroids and the response to the therapy, or even loss of expression, because that's something else we need to understand better. So I think here is for the short term and intermediate. For the long term is even more complicated. The regulators, they have different rules, but more or less about 5 to 15 years of data collection in those patients with hemophilia who have been through the adeno-associated virus, and in future even for the lentiviral for 15 years. I personally think for the first set of patients, we need to follow them for the rest of their life to understanding what is happening. We have seen recently, unfortunately, the first case of HCC in a patient with the uniQure clinical trial. But of course, that was a strange situation because the timeline was strange. It was too short time to think about the development of a cancer in a patient who had the gene therapy. And the very recent data, I think it was last week when the company came over with a declaration and I would say very good data analysis in terms of understanding whether the cells that show the hepatocarcinoma could have the integration of the genome, and what was the relationship between the gene therapy and the HCC. And the results most probably showing there is no correlation between the gene therapy and the hepatocarcinoma. But right now, we are dealing with a patient that they did have the hepatitis, cirrhosis, virus eradication, and we still are understanding what is happening after clearing up the virus. But which of these portions are really suitable for the future for gene therapy? And I think that should be really the subject of our research in the future for the scientific community, and trying to understand more and trying to collect the data in an accurate way everywhere in the world, and trying to link them when it's necessary and when the unknown side effects are coming up, in order to be able to come up with a similar type of signals. I hope there are no signals, but if there would be any, we have to have a good instrument to do it.
Thanks, Laura. And so one of the things that is interesting in this space, I agree with you on the integration. It's great to see that those results don't show that there was an integration event that caused the HCC. But one of the things that is becoming more common in terms of some of these gene therapies is the fact that it is quite a tough thing for the body to go through, and particularly in terms of liver health. We have the general population with fatty liver disease. We have discussions around alcohol use. We have discussions around health. We have discussions around the history of the individuals around Hep C, HIV, hepatitis B, possibly, and other aspects. So, I do think we're going to be discussing liver health a lot more. We might even be discussing liver health, outside of gene therapy as well as we go forward, because what we have seen around just general progression of liver health within the general population is something that with a history of hepatitis C and HIV, we should be keeping an eye on as well. So I think we've come to the end of the questions. I would love to continue this conversation on all of these topics all day, to be honest, but I know you guys have to get back to work. Thank you both for taking the time out this morning to discuss the possibilities for the future of hemophilia treatment, and our hopes and expectations as patients for improving the care and treatment in our joints long into the future. I really appreciate your time, and I hope you have a good day.